Good afternoon, everyone. Just for the help of our people in the booth, just state your name before you begin your testimony, and then after all four of you state your name so I know which name to put up when you start to speak. You'll start your testimony. You can start from the left or the right, your choice. You got it.
Thank you. Jonathan Tayan, I'm the CEO of the Associated Medical Schools of New York.
Caitlin Ethier, the Executive Director for New York American College of Emergency Physicians.
Christopher Arnold, United States Department and State Liaison Office.
Dr. Paul Papia, past president of the New York State Medical Society.
Thank you all. Okay. Whatever you want.
Great. So thank you all for the opportunity to testify this afternoon. I really wanted to spend a minute or so drilling down on an issue that was raised earlier today, which is funding for research, particularly NIH funding.
I really can't hear you. Can you hold the microphone closer or speak louder?
Sure. Is that better?
That's better.
Great. So I wanted to drill down on the issue of research funding, particularly NIH funding. So as a reminder, New York State has more medical schools than any other state in the nation. We have 17 medical schools here. We are now the second leading recipient of NIH funding, recently surpassing Massachusetts. We had $3.6 billion in NIH funding awarded last year. 70% of which was awarded to scientists at our medical schools. We are, needless to say, deeply concerned that last Friday evening there was a notice from NIH that would severely cap NIH expenses and reduce grants. We're at least somewhat comforted that yesterday there was a temporary restraining order on this cut, but we are very concerned that research in New York State would suffer from any cuts to NIH. Just to put this in scale, I mentioned $3.6 billion in funding. What this really supports is an awful lot of work done around the state that supports directly 17,000 jobs in research at our medical schools. In addition to that, this research really underpins our life sciences economy. What my request is at the moment is to firstly just ask the legislature to support academic medicine as we navigate some of these challenges coming from Washington, particularly as related to research. And then secondly, to really ensure that we fully fund state research initiatives that we currently have, which are few, but nonetheless very important. And I'll just note a few of those. The New York First program, which enables us to recruit and retain scientists at our medical schools, the Spinal Cord Injury Research Program, the ECRIP program, which was mentioned earlier, which was not included in the executive budget. And then quickly, I would also just really like to emphasize the importance of our ability to recruit and develop a representative and diverse physician workforce. AMSNY has been supporting pathway programs in partnership with the state for decades now that really help us diversify our physician workforce, and really want to make sure we continue those efforts. Thank you.
Good afternoon. Thank you for the opportunity to speak today. Again, I'm Caitlin Ethier with the New York American College of Emergency Physicians. We represent emergency medicine physicians from across the whole state. As many of you are aware, our healthcare system, and especially our emergency departments, which serve as the safety net of care, have been under enormous strain, which has only been exacerbated since the COVID pandemic. Our hospitals are facing unprecedented challenges, including record numbers of patients boarding in the emergency department, short staffing, lack of resources, and ever-increasing mandates. With that said, New York ACEP strongly supports Article 7, Part F, to codify the structure of the proposed MCO tax and establish a plan for spending tax receipts over the next 3 years. Among the first installment is an allocation of $50 million to support an increase in the Medicaid physician fee schedule to bring Medicaid reimbursement closer to the Medicare level. We ask that a significant portion of that appropriation be specifically earmarked to Medicaid reimbursement for emergency services delivered under Medicaid by physicians. Currently, New York ranks 49th out of 50th in Medicaid reimbursement in this category. Emergency medicine physicians are required by the Emergency Medical Treatment and Labor Act, or EMTALA, to provide and evaluate care for any patient who enters their door, regardless of insurance status or ability to pay. We ask that these financial resources be considered and allocated to the emergency physicians as they're necessary for these emergency departments to continue to meet the goals of EMTALA in a timely manner. Doing so would follow the lead of other states such as California. California was able to successfully allocate their MCO program to support increases to emergency physician fee-for-service and Medi-Cal managed care plans. Continuing, New York ACEP asks that the committees consider our position as strongly opposed to expanding the physician assistant scope of practice, which would allow PAs to practice without the supervision of a physician in a primary care setting or an Article 28 health system once they have reached 8,000 hours of practice. While non-physician practitioners such as PAs and NPs are an important part of the health team and well respected by physicians, their current training is within a physician-led team. While they spend many hours working within the team, it does not qualify them to practice independently. Similarly, how we would not allow paralegals to try a case in lieu of attorneys. For emergency physicians in medical school, they complete approximately 5,700 clinical hours, and then through either 3 or 4 years of residency training, they complete an additional 6,000 to 10,000 hours. By comparison, PAs have less than a quarter of these training hours. Thank you for your consideration.
Thank you, Chairman. Madam Chair, Christopher Arnold. I'm the Mid-Atlantic Region Liaison at the United States Department of Defense State Liaison Office. And on behalf of the Defense Department today, I want to highlight an opportunity for New York to enact a policy to protect its own residents while maintaining robust healthcare standards. The policy reflected in the Nurse Licensure Compact is fundamentally about licensure mobility, particularly for New York nurses serving our nation beyond state lines. These dedicated professionals face an impossible choice between their careers and their family's military service. Consider this: when New York nurses follow their service member spouses to duty stations across the country, no law that this body can pass can help them practice their profession in other states short of an interstate compact. Only this policy can provide this crucial bridge, allowing New York nurses to maintain their connection to their home state while serving elsewhere. The policy reflected in the compact is strictly about licensure verification, not practice standards. It's a straightforward solution that maintains New York's complete authority over all health care delivered within its borders. Every nurse practicing in New York, whether using a state license or a compact license, must follow New York's practice laws and standards with no exceptions. The evidence supporting the policies articulated in the compact's effectiveness is clear. A 2023 study demonstrates significant improvements in workforce participation and employment continuity for nurses in military families. Moreover, all 5 of New York's neighboring states have successfully implemented the policies in the compact while maintaining their high standards and state authority. New York law governs all nursing care provided to New York patients, period. The policies in the compact mirror New York's existing standards, so you're not lowering the bar, you're extending New York's high standards across state lines for our own residents. This is an opportunity for New York to lead, protecting its nurses serving nationwide while preserving its sovereignty and healthcare standards. The policy contained in the compact represents a practical solution to support New York's healthcare professionals who serve our nation. Thank you, and I welcome your questions.
Ready? Okay, thank you. I'm sorry. Good afternoon. I'm Dr. Paul Papia. I'm chair of the Department of Physical Medicine at Nassau University Medical Center, and I'm also the immediate past president of the Medical Society of the State of New York, and I testified here 2 years ago. The Medical Society of the State of New York advocates for more than 20,000 physicians providing care to millions of patients across the state of New York, and I thank you again for the opportunity to testify. The governor's health budget makes a number of modestly positive steps to enhance patient access to care provided by community-based physicians, including fully funding MSSNY's Committee for Physician Health Program, providing a modest increase to our woefully inadequate Medicaid payments that rank near the lowest in the country, and seeking to fix the unworkable requirement from last year's budget that requires a physician to obtain written consent for payment from a patient after, yes, after, health care services are delivered. But the good these proposals could achieve are more than offset by several returning problematic proposals that, if enacted, would drive even more physicians out of the state of New York. Once again, there's a proposal to impose a $40 million cost imposition on the 16,000 physicians receiving excess medical malpractice insurance coverage, requiring them to pay 50% of the coverage cost. Costs would on top of the already outrageous high medical liability insurance premiums that they already pay. Once again, the executive budget seeks to eliminate the right of physicians to appeal underpayments by the Medicaid plans to the state dispute resolution process. This provision would further impair the ability of hospitals to maintain the already strained on-call specialty care service availability and give Medicaid managed care plans a huge incentive to narrow their networks. Once again, the executive budget seeks to eliminate the requirement for physician supervision of many physician assistants. Despite the fact that MSSNY worked proactively last year with various legislators to help enact legislation to significantly increase the responsibility for PAs, including increasing the number of PAs a physician can supervise, permitting PAs to order durable medical equipment, and permitting PAs to initiate standing orders with nurses and a number of important diagnostic tests that will help expedite treatment for these patients. We are also very concerned that the general government budget proposal to eliminate the historic role of county medical societies in vetting physicians to participate in workers' comp program. The application process is not a reason for limited participation, but instead the often challenging process for obtaining proposals for patient care, excessive documentation, and significant challenges in navigating the burdensome process. Thank you.
Thank you. Senator Rhodes first.
Madam Chairwoman, thank you, Dr. Papia. There's not, I know you were here 2 years ago, and not many people want to come back, so I want to thank you for actually appearing a second time. Just a question, with respect to physician assistants expanding their scope of practice, I know you mentioned a little bit in your opening statement. What are your concerns in that area with respect to some of the proposals that have been advanced?
So the physician assistants are an integral part of the team. However, they were educated to be assistants to physicians, not to be independent practitioners, okay? There's a lot of stuff that they do. But giving them 8,000 hours, what is the quality of those 8,000 hours? Are they just parked in somebody's office? The 16,000 hours that I did, I had to display that I could perform in my field adequately and pass a board certification exam. Just accumulating 8,000 hours does not make them. There's nothing that stops them from quitting PAs and going to medical school. And the other speaker said what I said 2 years ago. For those of you who are lawyers, you're not going to let paralegals try cases. The lawyer tries the case. The paralegal is important to them, and we see that as the same position for physician assistants.
Thank you. I appreciate it. Just wanted to dovetail. I'm getting into a few labor issues today, which I didn't expect. But one of the governor's proposals, obviously, is to expand access to physicians beyond those that are coded by the Workers' Compensation Board to enable them to access more care. One of the concerns that's been expressed, obviously, is one, with respect to the coding process, but two, with respect to doctors that are not familiar with workers' compensation, now trying to practice in that field and have to navigate the complex world of getting medical records in through the Workers' Compensation Board. Does your organization have any specific position with respect to that?
Yes, we have two positions. One, very briefly, is that, as I said earlier, the county medical societies are the groups that is entitled right now and have been for many, many years to vet the physicians that are going into the workers' compensation coding program or getting a workers' compensation number. Additionally, a physician who's unfamiliar completely with the workers' compensation program can do as much damage as the injury itself. We would like to make sure that that if you don't put the right information down on the workers' compensation application, the workers will get terribly disenfranchised, and they'll lose their case, and we want to make sure that those injured workers get treated fairly.
I appreciate it. With 15 seconds left, I don't have time for another question, but thank you, Dr. Pepia.
Okay, thank you.
Thank you. Assemblymember Jensen.
Thank you, Senator. Yeah, just a quick question. First, I'm going to start with the Medical Society. One of my colleagues asked the commissioner about the governor's proposal to include a 50% cut to the physician excess medical malpractice pool. It's been in place for 40 years. What would be the impact on getting physicians to enroll and participate in that coverage if that money is disappeared?
Okay, so we've submitted 14 pages. I gave a very brief, one-page summary. I know for neurosurgeons practicing in certain areas will increase their amount into malpractice by over $33,000, depending upon which borough they're at. For years we've been asking to decrease the amount of, the amount of liability, and we have not been successful in doing that. So this second $1 million layer really helps out. And if you do not get rid of that 50% or you increase it by 50%, you'll just lose more and more physicians from New York State.
Okay.
So we're opposed to it.
Okay, thank you very much. Next question is for Mr. Arnold from the DOD, which is it's fun to have you testifying at the state hearing, so welcome. Could you explain how the military's basing scorecard system specifically considers licensure compacts and how this might affect future mission or resource allocation decisions in the state?
Thank you for the excellent question. So the fiscal year 2020 National Defense Authorization Act required the secretaries of the military departments to consider various quality of life factors when making strategic basing, stationing, or home porting decisions. The first factor is interstate license portability and the number of compacts which a state has joined. So in 2019, the Congress required the department to enter into a cooperative agreement with the Council of State Governments to develop interstate compacts. They made that authority permanent in 2024, and we thank Senator Rivera for his work with CSG. So we've developed 10 compacts so far, with another 2 under development, and there's a total of 18 that the department supports. States that receive higher ratings on the scorecard influence the basing decision, and it's not theoretical. The Air Force recently cited licensure reciprocity during the F-35 Joint Strike Fighter basing decision at Barnes Air National Guard Base in Massachusetts, who recently joined the NLC.
And you're not going to have time to answer this question, but would you be able to share with the members here any of the data that you have specific to New York-based service members about the economic impact that licensing delays have on military families?
Sure. So our data shows that military spouses lose an average of 4 to 6 months of income with every PCS move due to licensing delays, and the families move every 2 to 3 years. So with the average salary being $89,000, that's about $39,000 in lost wages plus the $1,000 for the license fee.
Thank you.
Continue with the assembly.
Good. Assemblyman Whitburn?
Thank you, Mr. Chairman. I also have a question for Dr. Pepia. I chair the Insurance Committee, you may know, and I regularly meet with physician groups and hospitals and other providers. One of the biggest issues I've heard from your membership and the medical community at large is the exorbitant amount of time spent away from delivering patient care to obtain prior authorization. A 2026 study by the Annals of Internal Medicine concluded that for every hour a physician spends on delivering care to a patient, 2 more are spent on administrative tasks. Under current law, health insurers are required to provide a determination regarding prior authorization requests within certain business days of the receipt of necessary information. This causes patients seeking prior authorization, particularly on days just prior to weekends and holidays, to stay in hospitals longer than needed. This often results in hospitals providing unnecessary and unreimbursed care to patients while waiting through the weekend or even longer for health plans to make these decisions. The executive budget did not include language requiring insurers to provide timely prior authorization determination. I have a bill to deal with that, you may know, and I'd just like to know your opinion and the feelings of your membership or MSSNY's membership on that issue.
Everything you said is true. There is a lot of waste in time and patient care, and sometimes immediacy, that you may just decide to do the test, not get paid, but make sure that the patient is well taken care of. The insurance companies, when they look at this, they look at it as a medical loss every time you provide treatment, because it's money away from their bottom line. So the answer is we support your bill, and we would like to see that process be streamlined. And if not, done, we should just get the ability to do it without having to wait for them.
Yeah, with my 42 seconds, my legislation also provides safeguards for patients with chronic conditions, such as ensuring that prior authorizations are valid for the duration of a given prescription, including refills and for the duration of treatment. How would this benefit your membership, and is that also something you'd support?
Every time somebody changes an insurance company, the panel of medications that they use get interrupted. Then you have to go through a whole process to get it approved again. Each company has their own guidelines for what they do. There's no universal thing. We would like to make sure that physician provider prevails in prescription medication.
Thank you. I look forward to working with you on it.
Assemblywoman Rosenthal.
Hi, my question is for Jonathan Tayan. In 2016, I passed a bill into law called the Beagle Freedom Act, which required research facilities in New York State to offer healthy dogs and cats for adoption after completion of any testing or research that was performed on them. And that's if they're still in shape to be adopted. And the law provided a chance to be placed in a loving home when their time in the lab is over. But the law does not provide a mechanism for announcing, if you will, that there are available dogs and cats. So I have a bill which would do that. However, I've heard that it's too difficult for schools to do and basic reluctance to do that. So can you answer why shouldn't these animals have an opportunity to have a good life after they've been used as testing subjects?
Thank you for the question. Harkening back to your 2016 bill, thank you for working with us to really make sure that legislation really works with the medical schools and research facilities. So I would say something I've said to you previously, which is really that our institutions that do use dogs or cats in research have for many decades been committed to adopting those animals.
Can you talk closer?
Oh, sure. Sorry about that. Our institutions have been, for many decades, committed to adopting suitable animals after research is completed. And so really our view is that we have existing channels for adopting those animals. We have communities around our medical schools that are aware of these opportunities, and frankly, it takes a special sort of person and family to adopt animals from a research environment. And so, what we haven't seen is that animals that are suitable for adoption, we haven't seen them not placed successfully. And so, our view is that we have existing mechanisms that work and find the right people for those adoptions. And so, our view again is that what we have now works effectively.
Well, part of my bill is, and the information is available on the USDA unless it's been scrubbed, But the bill says that each school has to have an adoption policy and report how many are being adopted each year. And, I've been told there's no way of tracking. Also, people don't know where to go to obtain these animals.
So, looks like we're out of time, but I'm happy to follow up about existing pathways. Thank you.
Thank you very much. My questions are going to be directed at Mr. Arnold. Thank you for being here, and thank you for your service and the great work that you're doing on behalf of military families. Could you explain the distinction between temporary licensing accommodations and the compact, particularly regarding New York residents stationed in other states? You have to turn your microphone on. There it is.
While temporary licenses provide short-term relief, they don't help licenses, or they don't help nurses obtain licenses in other states. So the department pursues a variety of approaches to reciprocity simultaneously. Our ask is that a state issue that state license within 30 days immediately. In the near term, we want to make those licensing practices accessible so that military families transitioning from states with different regulatory models know where they need to go to obtain their license, exactly what documentation is required, and how to fulfill that process. But our optimum end state are those interstate compacts, because if you're going from a compact state to a compact state, there's nothing you need to do. Your license is good to go.
Just making that transition that much easier. How does the compact specifically benefit Guard and Reserve components, especially during interstate emergency response situations?
Well, Assemblyman, first, thank you for your military service with the United States Navy, of course, but go Army, beat Navy.
Don't forget who won this year.
So compacts, in addition to benefiting military spouses, benefit all practitioners of the occupation. So whether that's civilians, Reserve and Guard component members, Reserve and Guard component spouses. And, in a disaster relief scenario, certainly having the ability for individuals to work across state lines is valuable. So New Jersey is a member of the compact, Pennsylvania is a member of the compact, Massachusetts is a member of the compact, Connecticut's a member of the compact, Vermont is a member of the compact. Those states could have emergencies. New Yorkers could be looking to work there. The licensing requirements are the same in all 50 states, and they're the same as the compact licensing requirements. So functionally, all you're doing is making New Yorkers pay for an extra license to go work in that other state. And that explains the differential between the number of licenses issued and the number of people employed, as a lot of those licenses go to people who are traveling to work in other states.
Understood. And in my remaining time, could you just quickly discuss the department's research on retention rates among service members whose spouses face licensing barriers versus those states in the compact in 10 seconds or less?
Sure. I submitted fairly detailed written testimony on that, and I'll certainly follow up with you or your staff.
Thank you very much. Appreciate it.
Assemblyman Mayer.
Thanks so much, all of you, for being here and for your testimony. I know that there's a lot of issues with licenses being given in a variety of medical fields. We had a very in-depth conversation with a bunch of our local dentist offices, and there was a lot of talk about being able to have some temporary licenses issued so that folks can start to work. What has been your experience with that? And I know some of it probably is some legislation that needs to get created, and how much of an impact would that make?
Assemblyman, if that question is addressed to DOD, and again, thank you for your service with the United States Navy as well, but I'm going to have to say, go Army, beat Navy. The Dentistry and Dental Hygienist Compact is one of the 10 compacts that DOD has developed with the Council of State Governments. In 2023, the federal government took action to require states to recognize licenses issued by other states. However, license recognition doesn't automatically represent a license in that state. And while the states are required to recognize it, employers are not, right? So employers want you to have that New York State license. So what the Secretary of the State's office has taken to doing, as well as the Office of the Professions, is issuing you a courtesy permit while you're here in New York State. If you present a copy of your military orders, it's good for the duration of your military orders, and we like that a lot. But what that does not do is help, New Yorkers who are dentists serving in other states obtain the license. So the compact is the only way you're going to be able to get after that. And what it also doesn't do is provide you with oversight. So, for example, the compact uses the NurseSys database system. So if you were to join the compact, the New York State Office of Professions would maintain full access and control and complete authority over your own data, but also get information from all the other states. So if another state suspends a license, that state is immediately, or that information is immediately available to all states. So that would enhance New York's oversight and provide additional tools for tracking nursing, dentistry, social work, psychology, all the compact occupations across state line. And that's particularly important for military families who practice in multiple jurisdictions.
Thank you. Appreciate that.
Thank you. Dr. Papia, we talked a little bit with the Commissioner earlier about the Medical Indemnity Fund. Obviously, this society has had concerns about malpractice costs in New York State, both in terms of just driving up costs and losing providers. So I know that additional monies were put in last year because it basically hit a circuit breaker, and we're back to that lower amount. Are you aware of any other measures that have been put in place to help deal with that issue that doctors in New York are struggling with?
For physicians, we've advocated, and certainly the 40 years that I've been in organized medicine, we've always tried to get that the malpractice would have a cap. That's not happening in New York, and it's not going to change. So the extra $1 million layer of coverage, and you have to have $1.3 million to even qualify for the second $1 million layer of coverage, it's not conscionable for us, in our opinion, for us to pay 50% of that without any kind of effective, New York State has the highest per capita payments in malpractice claims than any other state. The next nearest state to us is Pennsylvania, and all the way down the line is California, which is a much bigger state than us, but we pay much higher rates.
Okay, and I mean, what are you seeing in terms of the trends of doctors, either studying here and leaving the state because of those costs, or just closing up shop here because of those costs?
So we train, New York State trains 15% of all the physicians in the country when it comes to the residencies. And they don't stay here, they leave and go to other states because it's better for them in other states, less hassle, more ability to get paid, and less malpractice cost. So that's why they leave. At least that's our opinion.
Thank you.
Down here.
Assemblyman Jacobson.
The gentleman from the Medical Society. What's the percentage of successful malpractice cases, medical malpractice cases?
Okay. I know that malpractice cases are not always successful. On the side, if that's your case, I don't know the exact number. We can get back to you with that number. But the thing is this, there are many, many malpractice cases. You only have to watch TV to say, sue the doctor, and if you don't get paid, we
But
won't
in
charge
reality, there might be a lot of cases, but successful ones are far and few between. Isn't that true?
I think you need to also add into the amount of time that the demoralization of the physician from being sued, and all the other stuff that goes into defending those cases is a big waste of time for all the physicians, and a lot of anxiety, and a lot of reasons why they leave New York State because of the malpractice issues.
Well, it might be a waste of time, but wouldn't you agree that successful malpractice cases have changed the practice of medicine so that there's less problems in the future?
I would tell you that more people will leave New York State when they hear about the doctors that are getting sued for when they try to help patients out rather than medical mistakes. We've asked for many, many years to have medical courts where if there is a adverse reaction, that the person gets compensated. What really happens now, it goes into a legal system where the attorney who successfully does the case gets 1/3 of the compensation to the victim or to the patient who was wronged.
I just know that it's very difficult. There's so many exceptions. You go to a hospital and you get infected because it's one big petri dish, and that causes many complications of your surgery, and you can't sue because it's supposed to be an assumption of risk for that kind of problem.
I will tell you that the Joint Commission, which regulates all the hospitals, has one of their safety goals for the past couple of years is infection control, hand washing, and all the stuff that goes along with that. They are trying to do that. There are a lot of patients that get infected in a hospital, but we have done everything that we can to try and eliminate that from happening.
I hope so. That's all my questions. Thank you.
Okay. Now I think we have covered everyone's questions, so thank you very much for being with us today. Appreciate it. And I'm going to excuse
Thank you.
and ask the next panel to come up.